Today we'll talk about desmoid tumor. It is also known as fibromatosis, and aggressive fibromatosis or desmoid type fibromatosis. So I have compiled all the information mainly from Sabiston 21st edition and Schwartz 21st edition. So desmoid tumor histologically benign but locally invasive monoclonal proliferation of fibroblasts. So it's a benign but locally invasive tumor. So distant metastases are extremely rare or it's absent. Desmoid tumor is the most common primary malignant tumor of mesentery. Okay. So now come to the risk factors. So risk factors include trauma, pregnancy, important one, OCP, surgical incision, mainly over the abdomen and thorax, and most common presentation is prior at colectomy scar, and the women are it is more common in a woman, mainly young and middle age, 30 to 40 years of age, and then hormonal exposure, mainly the estrogen, increased estrogen level. Some syndrome related to desmoid, like Turcot syndrome. So somewhere you may be asked, like, what is Turcot syndrome? So it's a FAB plus brain tumor. Okay. The next syndrome is Gardner syndrome. So they may ask you what are the component of Gardner syndrome. So Gardner syndrome comprises of FAB, desmoid tumor, osteoma of the skull and mandible, sebaceous cyst, and cutaneous and subcutaneous fibroma. So it's a fibroma, sebaceous cyst, osteoma of the skull and mandible, FAB, and desmoid tumor. Okay. And desmoid tumor are usually preceded by colonic polyposis in FAB patient, and these represent the second leading cause of death in FAB patient. Other way of asking this question, after prophylactic colectomy, desmoid tumor becomes the primary cause of death in patient with FAB. So it's the second most common cause of death in FAB patient. Okay, and in FAB it is a most commonly intra-abdominal. Okay, most common presentation is intra-abdominal desmoid. Okay, the next one, location. Most common areas of origin include extremities, intraperitoneal, retroperitoneal, on abdominal wall, chest wall. Okay, and the prognosis mainly it's a very high likelihood of local recurrence, and intra-abdominal desmoid are more lethal than those occur at other anatomical sites. So intra-abdominal desmoids are more lethal. Okay. Okay. The larger tumor size, young patient, and extra-abdominal tumor location all predicts poor recurrence-free survival. So recurrence will increase if the tumor size is increased, young patient, and extra-abdominal tumor location. Remember is extra-abdominal. Okay. Okay. Now come to the pathology. So cyclin D1 dysregulation is thought to play a significant role in their pathogenesis, and WNT signaling pathway. So it's a WNT signaling pathway. It's related in syndromic and sporadic cases, but CTNNB1 mutation it's related to sporadic cases. Okay, so they may ask you in all cases you will get WNT signaling pathway. In sporadic cases you will get CTNNB1 pathway. Okay, okay, and then this CTNNB1 mutation express the stabilization of beta catenin. Okay, you just remember B to B. Okay, okay. So it's a slow growing tumor. It's a homogeneous and solid form, and it's non-painful. Huh? It's a non-painful. Okay, and the 70 to 85% cases arise sporadically. Okay, as I said earlier, it is more common in a female patient, but when it's associated with FAB, Males are affected as commonly as females. Okay. Okay. Now come to investigation. If they ask about the imaging study, you will say MRI. If they ask the diagnosis is established by core needle biopsy. Okay. Since this is related to FAB, so you should go for screening colonoscopy. Okay. Okay. Now come to the treatment. The the primary approach could be more conservative. Okay. Surgery for intra-abdominal desmoid tumor is generally is not recommended. Okay. Okay. Now, in which case you will go for watchful waiting. So, so this tumor may go spontaneous regression. So you can watch the patient. Huh? Okay. Now, if the tumor is not causing any severe symptom, you can also watch. The tumor is not related. Tumor is related to very critical structure, like if in which surgery is difficult, so you can watch the patient. And stable intra-abdominal desmoid tumor. Okay, so intra-abdominal desmoid tumor, you will prefer watchful waiting, and this is more lethal. Okay, two important point. If the tumor related to any critical structure and not causing any severe symptom, okay, and if the we will wait for spontaneous regression. Okay. So now come to the surgery. The gold standard treatment for abdominal wall desmoid tumor historically is a margin negative resection with immediate mesh reconstruction. Okay, so it's abdominal wall desmoid tumor. You should resect the tumor and you do mesh reconstruction. Okay, but if they ask you the ideal treatment, you should say it's a complete microscopic resection should be done. Complete microscopic resection. Okay. Or other way asking, you should go for wide local excision with 2 to 4 centimeter margin and intraoperative frozen section, okay, of the margin. Okay. If the desmoid tumor occur over the chest wall, you should go for chest wall resection, including involving ribs, one rib above and below, with 4 to 5 centimeter margin of the rib. Okay. Okay. Now come to the radiation. So we will go for radiation in if the tumor is positive or closed resection margin, and if it is a recurrent extremity tumor. Okay, remember it's a recurrent extremity tumor. Okay, now come to systemic therapy. In systemic therapy we have anti-hormonal therapies and NSAID. So these two used for slow growing lesion. Remember these two are important: anti-hormonal therapy and NSAID in slow growing lesion. Okay, you can also go for low dose chemotherapy like low dose methotrexate, tyrosine kinase inhibitor like imatinib, and full dose chemotherapy. Okay, so anti-hormonal agents such as tamoxifen have been used either alone or in combination with NSAID are the first line medical therapy. So this may be the MCQ. Okay. In pharmacological therapy with NSAID and anti-estrogen, so similar outcome to the surgery. Important one. Okay. So these are NSAID and anti-estrogen, so similar outcome to surgery. Okay. Now other modality like cytotoxic chemotherapy. Okay. So in which we give doxorubicin or carboplatin. Okay. So in which case we will go for cytotoxic chemotherapy if the tumor is aggressively growing. Okay, if the tumor is aggressive, we will give toxic. Okay, symptomatic if the patient is not a surgical candidate, and if the treatment is failed with anti-hormonal therapy and NSAID. So in all the cases we will go for cytotoxic chemotherapy. Okay, so combination chemotherapy including doxorubicin seems to the best option for progressive growing intra-abdominal desmoid. So you can remember this line: combination chemotherapy we will give for progressive growing intra-abdominal Desmoid. This is the CT picture of desmoid tumor. You can appreciate this desmoid tumor. Okay, so thank you.